So Miss Wilson is a 78-year-old woman with a past medical history significant for non-insulin-dependent type 2 diabetes mellitus, pancreatic insufficiency, and Alzheimer's disease, presenting with agitation and confusion, concerning for toxic metabolic encephalopathy, likely related to sepsis from UTI, plus or minus a diarrheal illness, now found to have an AKI.
Thanks for that presentation, Ashok. Flint, you're our resident. Do you have anything else to add to our student's presentation?
No, that was a great presentation, Ashok.
I agree. I think you did a great job. Let's take some time here to teach. What if the patient presented with a significantly higher white count and a clean urinalysis? Her current white count is 14, but what if she presented with a white count of 24? How would you think about this patient differently?
Maybe that the patient wasn't just sick, but really sick?
Great, and what else?
And maybe the patient had a severe diarrheal illness, maybe something like C. diff?
Excellent. That's exactly what I was going for. So Ashok, what do you know about the treatment for C. diff?
Not much.
No problem. Let's use this as an opportunity to have Flint teach. Flint, what can you tell us about the treatment for C. diff?
So the current standard of care for the first episode of C. diff is oral vancomycin. Ashok, do you know why we give it orally instead of IV in this case?
Is it so the patient can get discharged home with it? I'm not really sure.
Excellent guess, but it's because giving vancomycin orally allows the drug to have a very strong concentration in the colon, helping to treat the C. diff infection directly in the lumen of the bowel.
Great, Flint. But Ashok, what happens if the patient cannot take oral vancomycin because they have intractable nausea and vomiting? What would you do then?
Would we give the vancomycin IV?
Not exactly, but great thought. Flint, what do you think?
I know that they used to use flagyl, but that can't be right. Maybe we can give them a fecal transplant via NG tube, or vancomycin via an NG tube?
Great thinking. But if someone had a bowel obstruction, then we would not be able to go from above. The idea here would be to go from below. You can carefully use vancomycin enemas to help with this management. Of course, if you cannot get control with antibiotics, the definitive management is a colectomy. Flint, so tell me, what do you know about other medications that can be used to treat C. diff? You had mentioned flagyl before, but is there something else that we could have used?
I've seen fidaxomicin be used in the past.
Great. And how does that compare to vancomycin?
I assume it's better, but at least a step up from PO vancomycin.
So fidaxomicin, it's an interesting drug. As opposed to being bacteriostatic like PO vancomycin, it's actually bactericidal. The original study done comparing vancomycin to fidaxomicin showed that it was actually non-inferior to vanc. The only superiority that it showed was reduction of recurrence. And this was from a study in New England Journal of Medicine in 2011. The cost of fidaxomicin is also much higher than that of oral vancomycin, which is extremely cheap. With all that being said, let's talk about what we think the patient has. Ashok, what do you think of the underlying cause of the patient's encephalopathy is?
Well, I'm guessing it's C. diff since we just talked about it.
All right, good thoughts. Flint, what do you think?
Well, with the white count being 13, a positive UA, the patient having a recurrent history of UTIs, and with the patient not being able to take her pancreolipase due to limited PO intake, I think that it's still a UTI-leaned encephalopathy that makes the most sense. Generally, when I see folks with C. diff, they have more risk factors and appear sicker on presentation. I think we would be safe checking a C. diff and not starting empiric vancomycin at this time.
Completely agree, Flint, and I think that's a safe plan to move forward with for this patient. So here's a really tough question that I don't expect any of you to know. I only know this because it happened to a patient of mine, but wasn't anything I'd been taught before. If she developed toxic megacolon from C. diff and aspirated enterococcus, which enterococcus antibiotic would you not be able to give because it does not remain active in the lung?
I don't know.
Me neither.
It's actually daptomycin because it's inactivated by the surfactant in the lung. But thinking about the bigger picture, this patient has dementia and has had 8 admissions in the past year for a UTI. She's starting to show an increasing amount of resistance to antibiotics. When should we, as an inpatient team, start talking to the family about goals of care for the patient?
Well,